Good morning. Hi, Dr. Steve Wexner from Cleveland Clinic, Florida in Weston, Florida. I'd like to welcome everyone to our first Innovations Conference of 2012. On behalf of my co-moderators, Drs. Phil Schauer at the Cleveland Clinic main campus in Cleveland, Ohio, and the somewhat peripatetic Dr. Adrian Park. I'm not exactly sure of his whereabouts this morning, but I know he's online. We shall find out. I'd like to welcome everyone here to our first conference. I'd like to welcome the participating centers who are with us this morning, both Cleveland Clinic campuses, Carolinas Medical Center, Duke, Geisinger Medical Center, Johns Hopkins University, Lankenau Mainline Health System, and the Marks Colorectal Surgery Foundation, Mount Sinai Medical Center, Centaur Lee Hospital, Shaare Zedek Medical Center in Israel, the University of Maryland, the Virginia Commonwealth Medical Center, Walter Reed Hospital, and the University of Wisconsin. I'd like to also thank our sponsors, whose names you saw during the intro roll, for helping defray the cost of the conference. We've got a very exciting year with a lot of controversial and innovative topics being discussed. We've included quite a few centers who have not previously presented. For example, next conference on February 3rd, we'll be hearing from Dr. Lee Swanstrom from Portland, Oregon, from the Legacy Health System, and Lee is going to be speaking to us from the IRCAD Center in Strasbourg, France, on peroral endoscopic myotomy. So we have a lot of new and exciting things we'll be hearing about. We're also going to continue the theme of trying to introduce controversy and debate, and towards that end, this morning we have two views on the use of the robot in colorectal surgery, and specifically in rectal cancer surgery, and we've entitled it whether it's marketing mania or medical miracle. And speaking towards the view of the medical miracle is Dr. John Efron, who is the chair of GI surgery at the Johns Hopkins University, and speaking from the point of view of marketing mania, it's Dr. Marilise Bros, who's here with us in Weston, Florida. So I shall first give the floor to Dr. Efron to convince us all why we should invest in this technology and train and do our rectal cancers with the Da Vinci system. Ready to start off the 2012 innovations season, the rabbit chair at Hopkins, Dr. Efron. Welcome, John.
Thank you, Steve. Thank you very much, and thank you for the honor of being able to speak today. We're talking about rectal cancer, which is one of my passions, and approaching it minimally invasively, which is also one of my passions. So, can I actually have my slides? So I've been given the task of trying to convince you all today that rectal cancer should be approached minimally invasively, and if you're going to do it, you should use the robot because it creates a benefit. And one of the tough things about this talk is we have yet to have a lot of good data on how the robot impacts our ability to do minimally invasive rectal cancer surgery. One of the great things about this talk is we have little data to present about how the robot impacts our ability to do rectal cancer surgery laparoscopically. So I can give you just some of our own personal experiences a bit. But the robot is something that has gained popularity in its use over the last 5 years or so, and certainly from 2006 to 2009, if you look at the increase in the use of robotic procedures that were performed, it was a significant increase, 300% over those 3 years. But the robot is something that is, it's a quite expensive tool. It is a tool, and I think that's how we have to view it, as a tool. And if you view it as a tool, just like a vessel sealing device, it is quite easy to see how you could make an argument that it is beneficial for the use of rectal cancer surgery. That tool is a very expensive tool. It's approximately $2.3 million to purchase the console. You have to service it, which is quite an expensive proposition for hospitals. And you can reuse the instruments per case, but you can only do that up to 8, I think it's 8 or 10 times. It's 8 times, and after that they lock down and you have to buy new ones. So they're semi-disposable instruments. which adds costs to each procedure. And so the question is, the benefits you gain from the robot over a strict laparoscopic case, do those benefits outweigh the costs and the time commitment that come with it? Well, really, as I mentioned, there's limited data. There really has not been any randomized controlled trials to date comparing laparoscopic and robotic surgery that have been published. There are a few retrospective reviews, and in the last year we've had more retrospective reviews, not too many directly related to cancer. The ACOSOG trial that's currently underway does include robotic procedures, and that will be of great benefit to us. Whilst looking at the difference between robotic and laparoscopic surgery in that trial is not a main outcome, and so some of the statistics may be flawed. And looking at it certainly will give us an idea on some of the key things that we're going to look at today. Basically, there was only one non-blinded study looking at laparoscopic surgery compared to robotic surgery that showed some benefit. The other one showed that really there was no benefit or equal outcome with respect to complications, symptom relief, and blood loss. So what are the complications we see from rectal cancer surgery that is performed laparoscopically? Well, they're the same that we see from open procedures. Bleeding certainly can be a risk. Infection, quite a high risk, and that risk of infection, especially with open procedures, is quite significant, with most centers reporting wound infection rates somewhere between 13 to 25%, and if you don't have to make an incision, you certainly can decrease the risk of that infection rate. Anastomotic leak rate, we worry about that all the time. Most of these patients are diverted for that. Sexual dysfunction, which we understand well in men, but not in women with this operation. Bladder dysfunction, and conversion rate. Now, normally when I talk to the residents about laparoscopic surgery, I tell them you can't view conversion as a complication. So I don't really want to view it as a complication, but I certainly think that if there are tools that will allow us to prevent complication with these difficult cases, we need to utilize those tools. Positive margins and recurrence are short and long-term complications specific to rectal cancer surgery that's different from other rectal procedures. Laparoscopic surgery has been looked at, is still being looked at, and there's still quite a lot of controversy surrounding laparoscopic procedures and rectal cancer surgery. As we all know, rectal cancer surgery is a definitive operation that actually affects the outcome of the patients. The technical, the technique and the ability of the surgeon to perform the surgery will affect the short-term and long-term recurrence rates of these patients, and therefore we have to make sure that when we're doing a laparoscopic procedure, we have similar outcomes as to open procedures. This was a Cochrane database review from 2006, which had included a total of 4,000 patients. Only one of these trials was a randomized controlled trial with 3- and 5-year follow-up. Now, this was in 2006, and we now have other trials that are coming out, and as I mentioned, the ACOSOG trial is coming out. Basically, their 3- and 5-year survival of the 17 studies that were included showed no difference between the laparoscopic and the open group. The local recurrence rate showed no difference. Mortality showed no difference. Morbidity showed no difference, and anastomotic leak rate showed no difference. So in large complications and outcomes, there's really no difference between the minimally invasive technique and the open technique, and therefore I think we can say that the minimally invasive technique may add benefits that is related to short-term outcomes, hospital length of stay, cosmesis, complications that we don't necessarily, but without altering the long-term recurrence rates from rectal cancer. They found that the laparoscopic procedures had significant benefit in blood loss, GI recovery rate, pain scores, analgesic use, the immunologic response if it was assessed, and the length of stay in the hospital. What we do here, or what I do here with laparoscopic rectal cancer surgery, is a hybrid procedure combining a laparoscopic approach and a robotic approach. As I mentioned, the robot is a tool. I think the robot is a great tool for working in one quadrant where you have excellent visualization utilizing the robot, and it allows you to get adequate retraction, which sometimes is not available laparoscopically. But in the same breath, it does take time, and so I think combining the tools that we have, the laparoscopic tools that we have to do our mobilization, our intra-abdominal portion of the procedure, mobilizing the colon, mobilizing the splenic flexure, performing our ligations of the inferior mesenteric artery and vein through techniques that we're all very familiar with and we can do in our sleep, is basically a good thing. And then using the robot for the areas where laparoscopic surgery may have some deficits is also a good thing. You need to have you need to have experience when you're doing this. You need to have experienced assistance. Doing a hybrid approach allows you to only dock and undock once. When using the robot, people will also describe using the robot for the entire procedure. They bring the robot in at an angle, and that allows them to reach up into the left upper quadrant and down into the pelvis. But I found trying to do that you limit your reach in the left upper quadrant and in the pelvis, and therefore I think you're limiting your overall ability to use the robot to its best ability. The way I went about looking at what we needed to talk about today and to try and convince you wasn't necessarily that our overall outcomes would be better, but if we looked at specific problems that we find with rectal cancer surgery, will the robot help us decrease our complication rates that we see laparoscopically? So one of those is erectile and bladder dysfunction. And actually, there is very little written on both sexual and bladder dysfunction with respect to laparoscopic surgery, and even less with respect to robotic surgery. This article from Annals of Surgery published their rate looking at laparoscopic procedures, and they found that there was a 13% erectile dysfunction rate and a 2% bladder dysfunction rate, which I think if we look at the overall open series reported, for patients that have rectal cancer surgery done through open standard techniques, it's probably lower than what it is. And many people feel that your visualization of these structures is better laparoscopically, and I would say to you, though we don't have any proof for it yet, the visualization of the nerves robotically and your overall visualization, because of the excellent optics provided by the robot, at least in 2012, may provide us with some increased benefit and decrease our overall sexual dysfunction rates over time. And I think another really big area to look at when comparing laparoscopic and robotic surgery are conversion rates. If you look at some of the prospective trials that have been published to date looking at laparoscopic rectal cancer surgery, their conversion rates are quite high. The classic trial in 2005, which was published in The Lancet, had almost a 60% conversion rate when they were reporting on their rectal cancer cases. That is a very, very large conversion rate. And we do know there has been data to support that when you have a conversion from a laparoscopic to an open procedure, your complication rate tends to be a little bit higher, and there may be some data to support that even your local recurrence and long-term survival is worse. So what we want to try and do, especially with rectal cancer, is prevent that conversion rate. And the robot may help you do it. Well, how does it help you do it? It helps you do it by providing better visualization and also by providing better ability to gain space in a very small and narrow area by increasing the torque you can generate with the robotic arms. So why use a robot? Better optics, as I've talked about, better ability to control more graspers. The surgeon themselves control 3 graspers and the camera, whereas when you're doing it laparoscopically, you just have control of your 2 hands. You have these multi-articulated instruments which allows you to generate torque around the curve of the sacrum, which gives you better visualization and allows you to get lower in the pelvis. So really where the robot, I find, is of the most benefit is when we're dissecting down in the lower third of the rectum, getting way down deep into the pelvis. And most of the time when we do these procedures, we don't even make incisions. We will do a mucosectomy because it's just too low when we're doing these operations for distal rectal cancers to perform stapled anastomoses. Certainly for the surgeon, the ergonomics are better, and I don't have a backache when we're done, as opposed to doing a 4-hour laparoscopic proctectomy. And again, I think the generating torque forces that you can do with the robotic arms allows you to do patients that you would not necessarily be able to complete laparoscopically, or at least that I don't think I can complete laparoscopically, such as large, obese males, which I know we have an opacity of in the United States, but they are growing. The problems with a robot, you have no tensile feedback right now, so you generate these largest forces, and if you're not in the right plane, you can torque your way into a vein. It does increase the cost. You need increased training for your OR staff, and it can increase your overall time. Though it'll be interesting in compared trials to see whether the benefits of the visualization, the torque, will overall decrease our time when dealing with laparoscopic surgery. I think looking at rectal cancer, the data that comes out of Alessio Pagazzi's unit in California is probably still the best. He's published on outcomes, and this is not from his series, but this is another series that was reported on 106 patients in 2004, and they found no difference between the laparoscopic and the laparoscopic colorectal procedures and robotic colorectal procedures, but they concluded that it was safe to use the robot. This series also reported their first 50 cases, which showed that their conversion rate with the robot was 4%, which I think, again, if you look at overall conversion rates for laparoscopic or rectal cases, laparoscopic colorectal cases, that the conversion rates with the robot tend to be lower than they do with the standard laparoscopy. And then this, as I was mentioning, Dr. Pagazzi's actual cancer outcome data. Their conversion rate was 2.6%. Their length of stay was 4 days. Their short-term data showed excellent circumferential margins, all negative. Median lymph nodes of removed were 13, and they had no local recurrences in 13 months. And then if they looked at their 3-year follow-up of 64 patients, they had a conversion rate at that point in time of 10%, and this is taking all comers, an anastomotic leak rate of 7%, again, 15 lymph nodes resected, excellent local and overall recurrence rates, equivalent, if not better, to some of the open trials and laparoscopic trials. So I hope in the 10 minutes that I've given you a little overview on how we do this procedure, why we use it, and what some of the benefits may be for the robot in the use of the robot for rectal cancer. I think that we can certainly conclude that it's safe from the given data that we have right now. It's feasible. It's comparable to the standard laparoscopic procedures. Right now, because of the instrumentation cost, which I think will start coming down over the next 3 years, it certainly is a little more costly, but as you get used to the robot, as your staff gets used to the robot, the increased time in the operating room, I think we'll see drop to the same time as for laparoscopy. I certainly think we will see that the robot allows us to have a decreased conversion rate. We may see that it allows us to have decreased complications in such things as sexual dysfunction, where the visualization of identifying these nerves is better with the optics provided by the robot. And it certainly allows us to do these procedures in people that I think we otherwise would not have the ability to do it in. Thank you.
Thanks very much, John. Appreciate the insights. And I think what I'd like to do, instead of going around to some of the other centers for question and answer, we'd like to hear the other viewpoint from Dr. Boutros, and then after we've heard both sides of the coin, we'll go around and solicit some input from a couple of the other centers. So we appreciate the pro side, and now we'll hear a bit on the con side from Marilise Bros.
Thank you for the opportunity to present, and thanks, Dr. Efron, for your presentation. First, let's take a step back and look at laparoscopy as compared to open surgery. And in its infancy, in the first 10 years of laparoscopic surgery, there were 188 published reports of over 19,000 patients, including benefits of blood loss, improved less ileus, less pain, improved complication rates, especially wound infections, no doubt about an improved hospital stay, and long-term complications such as adhesions, bowel obstruction, hernia rates, and improved cosmesis. As laparoscopy matured, there are 700 more reports in the last 10 years, including 170,000 more patients, showing an improvement in immune response, cost, survival for stage 3 colon cancer, better preservation of urinary and sexual function, as we heard earlier, and perhaps better recurrence rates for Crohn's. So what's available in the robotic colorectal surgery literature? At first, it started with small case series, and up to date, there's 11 comparative trials. A closer look at some of them. One of the early comparative trials is a case-match trial of robotic to laparoscopic surgery, including 53 cases in each arm, with no specific advantages for robotic surgery. Looking specifically at robotic proctectomy, one of the published studies in 2009 compared 29 robotic proctectomies to 37 laparoscopic proctectomies, and again, no specific advantages, no oncologic advantages, and a significantly prolonged operative time of at least 45 minutes. Just published last year, Beck and colleagues compared 41 robotic cases to 41 laparoscopic proctectomies, and again, the oncologic outcomes were no different in the two groups, with the mean number of lymph nodes actually being almost significantly less for the robotic group as compared to the laparoscopic group. When you look at conversion rate here, there was no significant difference. When you look at post-operative outcomes, again, no significant difference, although there was a higher complication rate at 12% in the robotic arm. So at best, no real advantages to the robot. Another prospective comparison of 59 robotic cases to 59 laparoscopic cases published last year, again, showed a prolonged operative time for the robotic cases with no improved pathological or post-operative outcomes. For the only prospective study comparing open proctectomy to robotic proctectomy, again, no improvement in post-operative outcomes, overall morbidity, or pathologic outcomes, a result that's a bit surprising when you compare a minimally invasive approach to open surgery. Park and colleagues from Korea, who have a large robotic experience, did a three-way prospective comparison of open, laparoscopic, and robotic surgery, and again, found a significantly increased operative time with over an hour difference, and they felt that their learning curve was about 30 cases. Here they were well and above their learning curve. They found that ileus and postoperative morbidity were similar in the laparoscopic and the robotic arms, and that pathologic outcomes were no different in all arms. One study that looked at all of colorectal surgery but introduced the comparison of hand-assist surgery, again, found that robotic surgery was significantly longer than hand-assist or laparoscopic-assisted surgery with no other specific benefits. And finally, the only randomized trial out there with only 18 cases in each arm demonstrates no significant differences in operative time, although the robotic surgery was 217 minutes compared to 204, no difference in pathologic outcomes, and they report a 9-day hospital stay that's significantly longer for laparoscopic proctectomy compared to open. However, one has to wonder why laparoscopic proctectomies required a 9-day hospital stay, so at best a questionable advantage. So in summary, there's 57 published reports thus far in the literature as of last month in comparing robotic surgery to laparoscopic surgery with just under 2,000 patients with no proven benefits. One can't discuss robotic proctectomy without discussing cost, as Dr. Efron had mentioned before. In a study published in 2009 comparing open surgery to laparoscopic colorectal surgery with over 2,000 colectomies, they found that the advantage per episode of care was decreased by $15,000 when laparoscopy was used. And that was attributed to a significant decrease in complication rate and in hospital stay, again with a mean difference of $15,000. Delaney and colleagues started the discussion of cost for robotic colectomy in 2003 when they noted that robotic colectomies were over about $1,000 more expensive than a laparoscopic colectomy. Rawlings confirmed in 2007 that these costs came from operating room, personnel, supply costs, and increased OR time costs. In a study published in the New England Journal in 2010 where they reviewed all cost-effectiveness studies for all robotic surgery thus far, so about 20 procedures including robotic colectomy, they found an additional total cost of $3,000, a 13% increase. That's including the robot depreciation cost. Our colleagues in Europe compared robotic colectomy to laparoscopic and open, and again found a €2,000 difference between robotic and laparoscopic and open colectomy. When they specifically looked at proctectomy, they found that the difference was again over €1,000 per case, attributable to disposable materials, depreciation costs, or personnel cost. So with cost being a significant disadvantage, we move on to another area that might introduce some question or discontent. Are there lapses of judgment? Certainly, proctectomy is a challenging operation. Whether done open or laparoscopically, there's the challenge of the angle of the sacrum and narrow pelvis. Add to that a bulky mesorectum or a large tumor, and specifically in laparoscopic surgery with inadequate reach of some of the instruments and rectal division being difficult with endoscopic staplers not being able to quite make the perpendicular 90 degrees that you need all the time. Put on this an obese patient or a tight male pelvis and it makes it even more difficult. In addition, it's not only the difficult pelvis, proctectomy does recur in upper abdominal dissection, a difficult splenic flexure mobilization, and a good high ligation of the inferior mesenteric artery and vein. So definitely there's room for technical advances for proctectomy. I have to agree. Let's take a step back for a minute and look at the penetration rate of just laparoscopy and learn from our colleagues in Korea. In 2008, they published a 49% uptake of laparoscopic colorectal surgery at large. Specifically for proctectomy, they also reported a 48% uptake. Ourselves here in the United States reported in 2011 in the annals, up at 2008, there was a penetration rate under 20%. When looking at the impact of the COST trial from 2002-2004 compared to up to 2007, we were still at a less than 10% uptake for laparoscopic colectomy. But there are other differences between the United States and Korea. As Dr. Efron had alluded to earlier, obesity is a problem in the United States, with over 30% of our population being obese, whereas in Korea, that rate is only at 3%. Predicted prevalence of obesity is about over 50% in 2030, and Australia, England, and South America following right behind. At the American College of Surgeons, the audience was polled, and 600 surgeons were asked if they perform robotic colectomy. 10% said they did. 60% said they had the desire to learn robotic colectomy, and 80% agreed with Dr. Efron that the main advantage would be for the obese male pelvis. However, when asked who would market themselves for the obese male, 0% agreed. Another very disconcerting lapse in judgment is a patient here, just an example, referred to our practice this year, where a patient who underwent a robotic proctectomy, and as you see from the operative report here, that a complete mesorectal excision was carried all the way down to the level of the levator ani muscles. However, this patient was referred for an anastomotic stricture and a leak, and as you can see from his gastrograph and enema, his anastomosis is not quite at the levator ani muscles or close. So is this technophile kind of robotic surgery encouraging people to do things that maybe they're not quite ready to do? Here in the Wall Street Journal, reported in a low-volume center 2 robotic hysterectomies causing ureteric damage and just straightforward hysterectomy. So maybe a fool with a tool is still a fool. When we go on to look at one other lapse in judgment, is there's a lot of talk about unnecessary procedures at hospitals that now have a robot. Here, published in the New York Times just a couple months ago, saying that hospitals that have robots are performing more prostatectomies. In the New England Journal published last year, they report a 60% increase in the number of discharges of prostatectomies, so 60% more prostatectomies in 2008 than 2005. This is at a time where the incidence of prostate cancer is certainly not rising. If a patient were to walk in the door in 2008, they were 14% more likely to undergo a prostatectomy than in 2005. So is Mark Twain right that to a man with a hammer, everything looks like a nail? So hopefully in the future, the robot will have proven advantages. But as we are right now, what are the advantages? To the surgeons, possibly ergonomic. To the hospital, it definitely impacts their market share, as we saw. The shareholder, they're making a killing, but unfortunately, the patient hasn't benefited. Thank you.
Well, I see Dr. Efron's wandered off there, so I was going to...
No,
there he is.
I'm
Okay,
here, I'm here.
Okay. I thought you were going to defer to Mike there. I saw him sitting there with the microphone. Okay.
No.
Well, John, I'll give you or Mike the chance to offer a rebuttal, and then I know there's a few other people at other centers who are patiently awaiting a chance to weigh in on this issue.
Well, I think that, first of all, Steve, next time I get to go second. That was a wonderful talk. I congratulate for you. You presented a lot of the data very well and made some very convincing arguments. I mean, I think that any lapses in judgment with with people who are doing rectal cancer surgery can be present open, laparoscopically, or robotically. I always say that, you know, first to do minimally invasive, first to be a rectal cancer surgeon, you first have to be a rectal cancer surgeon. It doesn't matter what kind of surgeon you are, you need to understand the pelvic anatomy, understand the technique, and have a good experience in it. And then to be a minimally invasive rectal cancer surgeon, you have to have a good knowledge and technique of the minimally invasive tools that are utilized. When doing things laparoscopically, one of the problems is you have to have two skilled laparoscopic pelvic surgeons to do the case. And even at very large centers, such as Hopkins or Duke or any of the other universities, you don't always have two skilled surgeons doing the case. So even if you are a very skilled person, doing something laparoscopically without another skilled laparoscopic pelvic surgeon can be quite difficult. The robot may provide the ability to do these procedures without the same degree of skilled help that you would need laparoscopically. Certainly the data has shown that there is no clear-cut benefit over straight laparoscopic surgery with the robot. But I think we also have to be very careful in how we approach these things. If you look at the strict prospective randomized trials comparing laparoscopic colon surgery to open colon surgery, where there are no exclusion criteria, the only benefits that are generally seen, and I'm sure this is going to create some controversy, are associated with cosmesis. I mean, the cost study showed that and then perhaps a day, as Mike said, perhaps a one-day dismissal from the hospital earlier. I mean, if we really look at good scientific data comparing open to laparoscopic surgery and not just retrospective studies and case reviews, we tend to see that the benefits are probably not quite as good as we thought. And that perhaps is why over the last 20 years we have not seen a significant increase in laparoscopic colon and rectal surgery being done in this country and around the world, as we have seen with other procedures such as laparoscopic cholecystectomies or kidney resections or adrenalectomies. It's still only approximately 18% of the colon surgery done in this country is done laparoscopically, and that has to give us that has to provide us with some sort of insight into the fact that these procedures are still difficult and the tools we currently have are not adequate. And if you look at that for rectal cancer and pelvic procedures, I think you can almost double that. I mean, it is a very difficult procedure to do laparoscopically when you have two skilled surgeons. So I don't think a fool with a hammer is still a fool or whatever. I think that people have to approach rectal cancer appropriately. And I actually only use the robot selectively for rectal cancer surgery because I think there are rectal cancer procedures that shouldn't be done laparoscopically or robotically. You can't approach it from a marketing share. You can't approach it from an advertisement perspective. You have to approach it as you would using any other tool we do laparoscopically, such as the ligature or the end seal or the harmonic scalpel. All of those tools have significantly decreased our the length of time we spend in the operating room doing laparoscopic colon surgery. I think that for the most part, all over the world, they are utilized, and they're utilized for a reason. They make our life easier. So sometimes, just because we don't necessarily see a benefit as compared to standard techniques with respect to patient outcomes, as long as the patient outcomes are similar, which I think the majority of the limited data we have right now have shown that if they make our life easier, there may be some benefit to that. Thank you.
Thanks, John. I think what I'd like to do is turn the mic over to Carolina's Medical Center, who's patiently waiting, Rick Green and his team. Good morning, Dr. Green.
Good morning, Steve.
You have good morning. Nice to see you. Have a question or comment for us on this debate?
Well, I think this was a very timely session. I'd like to ask Dr. John Martini to make some comments. John is probably our most experienced robotic surgeon, and he's actually a proctor for Intuitive in teaching this. So, Dr. John Martini.
Sure. Well, good morning, everybody. First of all, I'd like to say to Marilise, I guess you got sick of the cold in Montreal and moved south, so it's good to see your rebuttal. I would say when you look at the data for this, you have to be careful when you interpret some of the outcomes because there's more than a 10 or 20 patient learning curve. And so when you're comparing, let's say, open or laparoscopic experience to robotic series, most of those series underestimate the amount of time it takes to learn these procedures. I don't do colon surgery. I'm a hepatobiliary surgeon. So I would say it's taken me more than that number of cases to get where I'm comfortable and proficient. And I no longer need to have an assistant with me. I have a scrub nurse or a resident with me. You don't have to have two surgeons. So I would just say it's good to be skeptical, but I also would say that we can't write off doing robotics at this point for any of these procedures. And that's really all that I want to say.
No, I certainly appreciate that comment. I believe we're going to be hearing from you a little bit later in the season from Carolina's Medical Center on robotic distal pancreatectomy, if memory serves correct.
Yep, that's correct. I think in March.
Yeah, so we look forward to that. We're going to hear some of the data and continue the dialogue in March. I also know patiently waiting is my co-host Adrian Park, who may be available only by audio from the Anne Arundel Medical Center in near Annapolis, Maryland. Adrian, are you online?
Yeah, hi, Steve. We can be heard but not seen, every parent and moderator's nightmare. So a couple of comments. Appreciated these presentations, just wonderful presentations. The ergonomics piece, just as one small piece, two comments. One is on the ergonomics and second is on training. The ergonomics piece, it stands to reason that there's benefit to the patient, to the surgeon, using kind of a computer-assisted surgical platform. That hasn't yet been shown. There's a study that we and a couple of other centers are trying to undertake to actually look at that, whether there's a wholesale advantage or simply a switch in the areas of focus where there's ergonomic risk factor violation, as opposed to, that is to say, as opposed to lower back and maybe cervical spine issues. But anyway, that remains to be seen. But I'm optimistic that one of the advantages may be to the benefit of the surgeon through a computer-assisted surgical platform. The other issue that really concerns me is potentially the loss of surgical skill, and that we avert our attention from laparoscopic training and residency and other places. And so when folks get into difficulty, unable to proceed robotically, the skill set is not there to complete the procedure laparoscopically. I am concerned that this is going to start diverting attention from developing expertise in laparoscopic surgery.
That's an interesting comment, Adrian, the second one in particular. The first one's interesting because I don't think the carriers necessarily care about our comfort or ergonometric benefit in terms of payment, but it's a good point. But the second one is exactly the same as we used to say when we started laparoscopy more than 20 years ago, that what happens when you need to convert to laparotomy, will anyone be able to do it? And certainly time will tell, but it's a very salient question. Thanks for that comment. If we could please turn to the Mount Sinai Medical Center in New York, I want to ask Barry Salke and Mike Eady and the crew up there, who do a lot of, have been doing a lot of laparoscopic surgery in the colorectal arena for more than 20 years again. And good morning at Sinai. Barry, be curious your views on where the robot fits in pelvic surgery for rectal cancer.
Yeah, Steve, good morning. Can you hear me?
Yeah, we've got a very peculiar view down the table there, like a ski just the land there.
I'm sitting in the
You're
back.
getting ready to go back to Colorado. I can see that. You're getting ready to head back to Aspen.
Yeah, that's true, but that's besides the point. So, yeah, I have a couple of comments. I was just came back from Hong Kong, where Michael Lee was doing his third annual course, and I was treated to 3 robotic procedures. 2 of them having to do with the, actually 4, excuse me. 2 of them having to do with the thyroid, by Korean surgeons, clearly technically skilled in both thyroid and robotic surgery. One Roux-en-Y bypass, biliary, hepatobiliary by someone also very skilled, Giulia Noti, and one liver resection. And there was also some regular, straightforward laparoscopic surgery, of which I did one case and a few other things. So my take on it, and I don't do any robotic stuff for a variety of different reasons. We could talk about that later if you want. My take on it is that the robotic procedure, using the robot, has developed into a separate technical exercise. I don't see it as really two-dimensional laparoscopic surgery at all. I think it's just a different way of approaching something. And I like the way that John is sort of approaching it, in that he's using it for limited indications, because, I mean, clearly the marketing of this tool has been over the top. I don't think there's any question. Even the people who do it are sort of feel that way. So the question is, can we really afford to do that in this day and age of economic considerations for what's going on in medical care? I mean, clearly, I can't answer that question, but to me, that's the issue. I think you'll have a lot more to stand on if there's some way of showing some clinical improvement. But the way that I see it right now is that there is zero clinical improvement with a lot of extra costs associated with it. So I don't know if that's, I mean, that's the way I take it. Now, saying that, there is some robotic stuff being done here at Mount Sinai, not by me, but some of the colorectal people who are in the room, Alex Key and Alex Kemp. So I don't know if they have any comments on it, but that's the way that I see it.
Hi, Dr. Wexner, it's Alex. You know, I've only done a handful of them here at Sinai, but however, I wonder how many patients might benefit from not having an APR from a better visualization, or able to get a lot lower than even a laparoscopy, because especially when they talk about the narrow male pelvis, sometimes with the laparoscopy that can also be challenging. So how many rectums are we actually saving that may not be measurable at this point?
It remains to be seen where we can define those benefits, but I also think that one of the points made in terms of the volume of cases being done certainly enters into the equation, and somebody, you know, like Barry or Rick Green in their respective fields who've been doing, you know, thousands of laparoscopic cases undoubtedly will have a potential difference to handle a problem laparoscopically than will somebody who's done a couple dozen cases. The robot may facilitate, because it's easier. It's kind of like having, you know, power steering instead of manual steering or power brakes. It just makes it easier, you know, to do things. And so it's kind of an equalizer, and that's the tremor filter and the 3D, but not necessarily everybody needs that or benefit. And, you know, but we will certainly see with time. I don't want to go too much over, but I just am curious if there's any other comments. I want to go to one other center that does a lot of rectal cancer work, and that's Lankenau, and John Marks, to hear the view there, because you talk about low resections and the ability of laparoscopy perhaps to be or robotic to be superior, laparoscopy to inferior for distal lesions. And here's a place where distal lesions are routinely approached by John and Jerry as well. John, could you comment on if the robot is going to change your management of distal rectal lesions, and if laparoscopy is a limiting step in approaching these lesions?
Well, Steve, thanks. First, I'd like to congratulate both of the speakers for excellent presentations. And a lot's been put on the table. I think that I would clearly take exception with the comment that you can't operate deep in the pelvis laparoscopically. Having done over 300 cases in the distal rectum laparoscopically, I think we've demonstrated, A, that can clearly be done with excellent oncologic outcomes. The real question in my mind has to do with, I think what this session has brought to bear is the fact that there really, to date, isn't tremendous data one way or the other. And that's not surprising. It took a very long time to have any convincing arguments in the literature that there is a benefit to laparoscopy over open surgery, even though those of us who were performing it could clearly see that in our patient population. And it's somewhat striking to hear John say today that the only benefit that's been shown has been cosmetic. I would take exception, as I think many in the room would. As for the benefit of the robot, I think that that's going to be really time will tell. I think clearly the visualization in the pelvis, while you can see things very clearly laparoscopically and do it, robotically it is quite appealing when you sit at a console and look down in the pelvis. And the challenge is going to be to get people who are experienced laparoscopically in the pelvis to then become experienced with the robot and see how that can be utilized, as well as recognizing that to date we're still really using relatively early generation robotics. And so I think this is the very beginning stage of robotics. I think it's an exciting opportunity. I think to date it's not a major game changer, except if it's going to allow people to do things they wouldn't otherwise be able to do. I think clearly these things can be done laparoscopically, and the question is going to be if we can do it easier or better with a robot. Thanks.
Thanks, John. And for the last word, I'm going to turn it over to our co-host, Phil Schauer at Cleveland Clinic main campus in Ohio for a comment. I know we're a few minutes over, but I'd like to give Phil the opportunity.
Good morning.
Or
I'll be quick.
the rest of the team in Cleveland.
It's actually Meg Castedio, and I'm one of the new staff here at Cleveland Clinic, and I'm doing robotics and a lot of laparoscopy. And I wanted to thank you both for your wonderful presentations, and I completely agree with both sides. And a lot of people really feel that the benefits of robotic are that it is easier, and I wanted to put out a word that it also has a learning curve. So it's not always easier the first few cases. So it's something to be learned, just like laparoscopy, just like open proctectomies. And it's not always going to make especially when you're doing the harder cases robotically, easier. Now, that being said, once you pass that learning curve, there are benefits, as Dr. Efron said, but the first few hurt just as bad as the first few hard laparoscopic cases.
Okay, thanks, Megan. With that, we're about 10 minutes over. I want everybody to thank both Drs. Efron and Boutros for some wonderful presentations, and everyone at all of the centers for participating in the lively dialogue. Our next conference will be on Friday, February 3rd. Again, Dr. Lee Swanstrom from Legacy Health in Portland, Oregon, who's going to be over at EARCAD at Jacques Marasco's place in Strasbourg, France, presenting on the per-oral endoscopic myotomy, moderated by Adrian Park from Maryland. So thank you all once again for coming this morning, and I wish you a good weekend and a happy and healthy new year.